self-audit rounds, daily rounds, board round participation with cardiology team alone. Then provide drug information service using evidence-based medicine. Every time you have to do with every medication error or any overdose or underdose. Ruling out drug discrepancies in medication chart. That is a very tedious process of ruling out drug discrepancies in medication chart, because for one patient you have to spend half in the starting. When you start as a journey of a pharmacist, you have to be very vigilant for one in every single case. So 1 hour gets to advocate about one case. So you have to select your cases, like if any patient is having using more than 12 to 15 drugs, that case is your should be your choice. If patient is on high alert medicine, that case should be your choice. If patient is using on if a patient is on high alert high risk medicine, then that case should be your choice. So you have to be selective. You cannot screen every patient, because as we know that bed to patient pharmacist ratio is very huge. Like for one pharmacist, they hire for 100 bed, 200, 300 bed. Some hospital hire only one pharmacist, one clinical pharmacologist, or one clinical pharmacist. So you have to be selective in your approach. That's what the thing I'm going to tell. And do therapeutic interventions and dose adjustment. That would be your part. Alerting the clinician about any contraindicated drug is being given to the patient. So what you can do, you can just make a list of contraindicated drug at your hospital, and because similar hospital have often encountered similar type of diseases patients. Like there was one of the drug which was contraindicated in many things. Like in our hospital, they used to mix and give Digene syrup with uh, Ecosprin. So Ecosprin is a coated tablet. So it it sensitizes the acidic environment and breaks down. Sorry, basic environment, and its breakdown. So it gets break into stomach. Why the coating is done? To safeguard from the duodenal ulcer. Earlier, it is a corrosive drug. Whenever they used to take aspirin, the aspirin goes to the the esophageal region, and they used to cause the ulcers in that part. So what the pharmaceutical company did, they coated the tablet. So but nurses, doctors, they don't understand this. So you have to tell. So in our hospital, what they used to do, they used to give antacid, like for example Digene syrup and then Ecosprin together. So the coat was useless. Sorry, that was useless. Why? Because Digene syrup is interacting and the drug is getting braked before it reaching the stomach. So there was no use of giving that. So I stopped that practice. So that was constant in everything. So this was one of the meaningful intervention which I did. Second meaningful intervention which I did was, like they used to give every patient indomethacin suppository. So even every CABG. So whenever patient serum creatinine is more than 2.5, you cannot give indomethacin suppository. There was third intervention which I did. Patient was of phenylketonuria, and such kind of patient has lactic acidosis, phenylketonuria, and if serum creatinine is 2 or 2.5, you cannot give such patients um, metformin. That is contraindicated. So I told the diabetologist. So this is how you have to find out your cases. These are the learning which you get. So then providing drug information, then doing alerting the clinician about any contraindication, make a contraindication list and then provide them. And give inputs to improve prescribing practice in the hospital. This you can do. Advise addition and deletion of any drug from drug formulary. Such kind of cases which are usually done. So I want to discuss few cases regarding cardiology cases which are exemplary whenever you will go. So now as a quality manager, I can divide the process of medication management of medication into um, admission while admitting the patient, in when patient is in ICU, while patient is in ward, while patient is inside the OT, while patient is getting discharged. All these areas, they have a chance of getting a wrong medication to the patient. Or so I would like to discuss one case. There was one of the case. I'll just end show and I'll just yeah. So I'll stop sharing and I will just now interact you directly. So there was one of the case which I saw was the practice of that hospital was like they had a BHMS doctors as an RM. So BHMS doctors are not so much trained in allopathy system of medicine. They don't understand. Even they are trained, then also they have potential to do errors. So what happened actually? Patient was patient of uh, patient was elected for patient was due for elective surgery of CABG. So before CABG, they will stabilize the patient. So to stabilize the patient, they will ask have a cardiology opinion, an ICU, an internal medicine expert opinion, and an anesthetist opinion. So three people are involved in that. Before shifting the patient to OT, three people see the patient and they confirm that patient is fit for surgery. They give the fitness test and then patient is shifted to the OT for procedure. But what happened with this patient? That hospital had a problem, a common problem, that the medication history and the medical history is taken by the RMO, and it has been documented. RMO don't understand the importance of medication history taking. So what they omitted metoprolol 50 mg, 50, which patient has been taking since years. So when body is dependent to any beta blocker, if you see AHA AACC guidelines, American Heart Association cardiology guidelines, you will see the importance of beta blocker is so that patient body is dependent to the beta blocker. You cannot stop abruptly, and you cannot stop it, and that is not a drug to be stopped. You can increase the dose, you can add some other, but you cannot stop it. Why? Because your body vasculature is been adapted with that beta blocker on that dose. So but they didn't knew about it, that they thought but they didn't knew that patient is being taking or not, so they omitted. Then patient was seen by an internal medicine doctor. Internal patient is labeled hypertensive, and patient was on telmisartan amlodipine. So Telma AM. So patient was on Telma AM. Then patient was on blood pressure controlling medicine. So consultant agreed that this would be the case. So he also ignored. Then it came to the limelight of a anesthetist. An anesthetist thought, okay, everything is done. All said and done. Even a cardiologist has done. It is okay to shift the patient, because history taking is very narrow part and which has been highly ignored. So what happened actually? Patient went to OT. After three clearance, patient went to OT. Patient had atrial fibrillation on OT table. Patient had AF, and on the OT table, patient was managed and patient came out from nowhere. Patient came out. Patient was stabilized. Then patient was shifted to ICU. So, and if you see the duration when patient stopped the medicine and patient had an OT was of 7 days. So it was 7 days patient was without beta blocker, and doctors were controlling by other medications. So you see, in case of abdominal surgery or thoracic surgery, there's a sympathetic shoot associated. Whenever you cut the part of the body from, so the nervous system they reach is the response and they increase the cardiac activity. So and that happens during patient is under anesthesia in deep sedation. That also happens. So this was a gross error which could not have been neglected. But who brought this in front of everyone? I saw this. I took 3 to 4 days. I asked the cardiologist, I asked the ICU team, I asked everyone, I searched the literature, I find what is the grade level of evidence is this. Then I presented that and they accepted and it was a fault and they was penalized based on my report. So this was one of the report. Now I would like to discuss the second case, which is an ICU related case. There was a patient of thyrotoxicosis. To control thyroid storm, you have to inject the patient with hydrocortisone, or you can start with the therapy of methylprednisolone. So steroids are used to control thyroid storm or thyrotoxicosis. This is the novel thing. This is the standard practice. Now, this was a problem with the process of medication reconciliation. Patient was receiving hydrocortisone at the three doses of hydrocortisone in ICU through injection. Then patient was shifted to the ward. There is a term known as IV oral conversion. So you have to learn these terms. Like 100 mg of hydrocortisone is equivalent to 30 milligram of methylprednisolone, 1:3 ratio. So these kind of things are available. You can easily read what is the IV oral conversion. It happens with the antibiotics also. So, so the doctor was not aware about it. He while shifting the patient, he did the same mistake, and he never converted. So what he was stopping the hydrocortisone. He put his stop orders first, and then he shifted the patient. Patient was received in the ward. Patient received hydrocortisone as well as methylprednisolone in the ICU also, and patient was seen in the ward, and it was found in the ward the patient was taking since 3 days. So there was a therapeutic duplication of medicine. So this is also gross, even it is a high risk medicine, and you are giving it for 3 days. Now, next thing case was a classical case. I would like to tell you, there was one case. Then patient was given like if this injection, if you know iron supplemental, elemental iron injection you have to give it once a week. So once a week is a protocol. But many gynae doctors, they recommend the patient uh, in one go 3 days or 4 days. But this does not will increase the iron concentration in the, and it won't lead to increased hemoglobin. It would never do, because there is a way in which it is loaded on the over the body. So so I had advocated this concept. I advocated and presented my this theory that this is a wrong way of giving IV iron therapy. So that iron therapy was given wrong. So then then the doctor didn't agree, but I told him that diligently that you are actually wrong, because there's a posological factor which are associated, which you might not know, but we know. And so I presented this report, and all the clinicians, they accepted it. So there are few cases which are really need to monitor, because you in cardiology settings there is very less clinical intervention by an internal medicine doctor. All are cardiologists, all are anesthetists. So then and surgeons. So they are less perfect in guiding the drug therapy. So now your part comes into play. So those things in a clinical cardiology settings you have to take care of. So these were the things I wanted to discuss, and I think I'm. Thank you so much. I think my presentation is over now, and I would like to take leave. Thank you. If you have any doubts, please you can ask.